Picture this. A 58-year-old man walks into your consulting room. Blood pressure 158/100. You start him on amlodipine. 2 weeks later his back. Ankles swollen. Headaches. He stops the tablets himself. Sound familiar? It should, because medication side effects are one of the biggest reasons blood pressure stays uncontrolled in this country. Good morning. It's Friday, July 31st. 4 stories today, including a massive meta-analysis that changes how we choose blood pressure drugs, a trial that shifts the conversation around atrial fibrillation ablation, and something for your wife on tranexamic acid in Caesareans. Let's go. Story 1. That opening scenario, the patient who stops his blood pressure tablets, is exactly what the George Institute tackled in a landmark network meta-analysis published in JAMA in June. NASA's Wang and colleagues, including Aletta Scott, Marcus Schlake, Anushka Patel. Australian names. Australian-led research. They analysed 716 double-blind randomised trials. 159,000 participants. Every major blood pressure drug class, alone and in combination. The question was simple. Which regimens actually cause patients to stop treatment due to side effects? Here's what they found. And some of it is genuinely surprising. First, calcium channel blockers, drugs like amlodipine, cause significantly more discontinuations than placebo. About 1 extra dropout per 100 patients. The ACE inhibitor plus calcium channel blocker combo, think perindopril plus amlodipine, also had more discontinuations. And beta blocker plus a thiazide was the worst offender for dropouts. But here's the twist. Every regimen containing an ARB, an angiotensin receptor blocker, had fewer discontinuations than placebo. Not just fewer than other drugs. Fewer than a sugar pill. ARB monotherapy had fewer dropouts. ARB plus calcium channel blocker, that was the best tolerated combination of all. Patients on it actually felt better than on placebo. Think about that for a second. We've always assumed blood pressure drugs make people feel worse. This data says some combinations make people feel better. The mechanism? Blood pressure lowering itself reduces headaches. And ARBs are clean drugs with minimal off-target effects. Why does this matter for your practice? Because blood pressure control rates in Australia are terrible. Roughly a third of treated patients are at target. Side effects, or the perception of side effects, drive a huge amount of non-adherence. This paper gives you evidence to say to your patient, let's use an ARB-based combination. The data says you'll tolerate it better. The editorial accompanying the paper puts it bluntly. Combination therapy should be the first-line option. Not stepping up from monotherapy. Start with 2 drugs from day 1, preferably an ARB plus a calcium channel blocker. We knew combination therapy was more effective at lowering blood pressure. Now we know certain combinations are also better tolerated. Now why would a blood pressure drug cause fewer symptoms than placebo? Part of it is mechanical. High blood pressure itself causes headaches. Lowering it, regardless of the drug class, reduces headache frequency. The network meta-analysis confirmed this. Every drug class except calcium channel blockers reduced headaches compared to placebo. Calcium channel blockers were the exception, because they cause vasodilation that can trigger headaches. And ARBs, in particular, are remarkably clean. No cough, unlike ACE inhibitors. No significant edema, unlike calcium channel blockers. No metabolic disruption. So patients feel the benefit of lower pressure without the burden of drug-specific side effects. One caveat. These are short-term trial-level results, averaging about 8 weeks of follow-up. Individual patients may still have idiosyncratic reactions. But the signal is strong and consistent across 700 trials. This is the paper you cite when justifying your combination choice to a skeptical patient or a formulary committee. Story 2. Something for the obstetric side now. Tell your wife about this one. Placenta Praevia. You know the anxiety. A woman comes in for caesarean, placenta right over the internal OS. The blood loss risk is real and elevated. We already give oxytocin prophylactically. But does adding tranexamic acid make a difference? A phase 3 trial published in the BMJ in May asked exactly that. 1,732 women with placenta Praevia undergoing caesarean delivery, across 24 hospitals in China. All received prophylactic oxytocin. Half got 1 gram of 4-tranexamic acid within 5 minutes of cord clamping. Half got saline placebo. The result? Postpartum hemorrhage, defined as 1,000 milliliters blood loss or need for transfusion, occurred in 30% of the TXA group versus 35% of placebo. A 15% relative reduction. About 5 fewer major bleeds per 100 women treated. And crucially, no increase in serious adverse events. No excess thromboembolism. No seizures. No kidney or liver injury. The rates of serious adverse events were identical at 0.5% in each group. Now, the effect size is modest. And in an Australian context, many obstetric units already use TXA for high-risk caesareans. But this is the first large randomized trial to nail down the benefit specifically in placenta Praevia. The number needed to treat is about 20. Treat 20 women to prevent 1 postpartum hemorrhage. For a condition where the baseline bleed rate is 35%, that is clinically meaningful. The discussion point for your wife. This trial enrolled women with placenta previa specifically, not the general obstetric population. Nearly 18% had placenta accreta spectrum. The benefit was consistent across the group. This supports routine prophylactic TXA in previous Caesareans, on top of oxytocin. And it adds to the growing body of evidence, including the World Health Organization's recommendation, that TXA has a role in PPH prevention for high-risk women, not just treatment. The context worth knowing. The Woman trial, published back in 2017, established that TXA reduces death from bleeding in postpartum hemorrhage when given as treatment. This new trial pushes the question earlier, into the prophylaxis space, and in a specific high-risk group. The beauty of TXA is its cost and simplicity. It costs about $5 a dose. It stores at room temperature. And it works within minutes. For rural obstetric services where blood products may be hours away, having TXA in the prophylactic protocol for previous Caesareans is a cheap, high-value intervention. Story 3. Back to cardiology. And this one changes the referral conversation. You know the patient. 62 years old. Persistent atrial fibrillation for 3 months. Symptomatic. Palpitations, breathlessness. You refer to cardiology. Traditionally, the guidelines say try antiarrhythmic drugs first. Flecainide, sotalol, maybe amiodarone. If they fail, then consider ablation. It's a stepwise approach. Tablets first, burning later. The Avant-Garde trial, published in NEJM in April, challenges that entire paradigm. 310 patients with previously untreated persistent atrial fibrillation. Not paroxysmal. Persistent. Randomized 2-to-1 to pulsed field ablation, or antiarrhythmic drugs as first-line therapy. Every single patient got an implantable cardiac monitor, so arrhythmia detection was rigorous and continuous. At 12 months, treatment success, meaning freedom from atrial arrhythmias, was 56% in the ablation group versus 30% in the drug group. Nearly double the success rate. And the primary safety endpoint, device or procedure-related serious adverse events, occurred in only 5% of ablation patients. Now, what is pulsed field ablation? It's the new technology on the block. Unlike traditional thermal ablation, radiofrequency, or cryotherapy, PFA uses electrical pulses that selectively target cardiac muscle tissue while sparing adjacent structures like the esophagus and the phrenic nerve. The safety profile is cleaner. This trial builds on earlier data showing PFA works for paroxysmal AF and now extends it to the harder-to-treat persistent form. Why does this matter for you as the referring GP? The conversation with your patient changes. Instead of saying we'll try tablets first and maybe ablation later if they don't work, you can say the latest evidence suggests ablation may be the better first option for persistent AF. Of course, access varies. In rural Australia, this means referral to a centre with PFA capability. But the paradigm is shifting from ablation as last resort to ablation as first line for the right patient. Your role is knowing when to refer early rather than cycling through drugs that have a 70% failure rate. One honest caveat. 25% of ablation patients had a serious adverse event by 12 months, though many of these were arrhythmia-related recurrences rather than procedural complications. The trial was industry funded by Boston Scientific. But the effect size is large and the safety signal is reassuring. The bigger picture here is that atrial fibrillation management is undergoing a generational shift. We now have multiple trials showing ablation is superior to drugs for both paroxysmal and persistent AF. Pulsed field ablation, specifically, is gaining traction because it solves the safety problem that held back wider adoption. The risk of atriosophageal fistula, pulmonary vein stenosis, and phrenic nerve injury, rare but devastating complications of thermal ablation. PFA's tissue selectivity dramatically reduces them. As the technology reaches more Australian centres, expect earlier and more confident referrals. Quick hits now. First, the TGA has launched a major crackdown on black market peptides. Products marketed online as retatrutide, that's the experimental triple hormone weight loss drug still in clinical trials, plus BPC 157, TB 500, and CJC 1295. These are being sold through social media and messaging apps, often promoted by influencers. The TGA's chief medical advisor, Professor Robin Langham, warns these products may be counterfeit, contaminated, or non-sterile, and could cause serious health complications. If you have patients, particularly younger patients interested in bodybuilding or rapid weight loss, ask directly about online peptide purchases. And on a related note, TGA laboratory testing found that Eagle Research Lab branded SAIMs, selective androgen receptor modulators, were significantly underdosed. They contained far less active ingredient than the label stated. Both SAIMs and peptides are prescription-only medicines in Australia, but are being sold illegally online. Ask the question when you see unexplained symptoms in otherwise healthy young men. Second, the PBS pipeline for August. The headline listing is begunylyl alpha, brand name Elfabrio, for Fabry disease. It's a pegylated enzyme replacement therapy from Chiesi, moving from the life-saving drugs program to the PBS. Rare disease, small patient numbers, but important for those families. Also watch for Sofova, pegcetacoplan, for geographic atrophy in age-related macular degeneration. It received a positive PBAC recommendation and is in the final government processes stage. If listed, it would be the first PBS-funded treatment for dry AMD. Your older patients with central vision loss will be asking about it. And ANZCA is seeking representatives to help update the patient blood management guideline for adults with critical bleeding. The existing modules are over 10 years old and the evidence base has moved on. If you're involved in trauma or perioperative care in a rural setting, this update is worth following. Quick recap. 1. ARB-containing combinations are the best tolerated blood pressure regimens. Start with combination therapy, preferably an ARB plus a calcium channel blocker, from day 1. 2. Tranexamic acid reduces postpartum hemorrhage in placenta Praevia Caesareans, about 5 fewer bleeds per 100 women, with no safety signal. 3. Pulsed field ablation is now evidence-based as first line for persistent atrial fibrillation. The referral pathway is changing from drugs first to ablation first. And watch out for patients buying peptides and SARMs online. See you Monday. Stay sharp.